The next speaker is Dr. Shabnam Bobidwala, subspecialist trainee in reproductive medicine at the University of Southampton. And Shabs is specialized in pregnancy of unknown location and ectopic pregnancies, and her research has informed RCOG and ISOR guidelines. And she will speak about selecting women for expectant medical and surgical management of tubal ectopic pregnancy.
Thank you very much. Just bring up the talk. Brilliant. Thank you very much for the invitation to speak to you here today about how we can manage tubal ectopic pregnancies. So as with most things in medicine, there are three forms of management: expectant, medical, and surgical. With expectant management, there's obviously no therapeutic intervention, but we do serial serum HCG monitoring to watch them go down to a negative level, which is usually in most units either less than 20 or less than 15 international units per litre. With medical management, you can see there's a host of drugs that have been researched or trialled, but actually the only one that's in use in current clinical practice is metotrexate. And then surgical options are either open or laparoscopic, and either a salpingectomy where we remove the entire tube, or a salpingostomy where you essentially make a linear incision into the fallopian tube and then remove the trophoblast through that incision that you've made. As with time, with most things in medicine, I think what we found is that we've now had the confidence and the diagnostic tools to become less interventional. So back in the day is when we were at our most interventional, and actually it was all the way back in the 1800s that they first discovered that performing a salpingectomy, obviously all via laparotomy at that time, was an effective way to treat a tubal ectopic pregnancy, because expectant management at that time, so obviously before diagnostics and when women only came when they were really quite symptomatic or moribund, resulted in an 86% mortality rate. The first salpingotomy was performed in the 1920s, or certainly published in the English literature. And then it wasn't until the 70s and 80s that really laparoscopic approaches became much more commonplace, and we were performing our salpingectomies and salpingotomies through laparoscopic surgery. I'm not telling you anything new by saying, of course, laparoscopy is preferable to a laparotomy. You get shorter operation times, less blood loss, shorter hospital stay, lower cost, I think not just for the healthcare institution that's looking after the patient, but actually an important consideration is a lower cost to the patient themselves in terms of time off work, recovery time, lower analgesic requirements, less adhesion formation compared to having a big laparotomy scar. The subsequent successful pregnancy rate is comparable. What about the argument of salpingectomy versus salpingotomy? So this RCT of nearly 450 women done over a decade ago now found that if at laparoscopy you had a confirmed tubal ectopic pregnancy on one side and then the other tube looked healthy. Now, from the study, it's not clear, and I don't think they did routinely do dye tests to confirm patency, but certainly macroscopically, the contralateral tube looked normal. They found that actually if you compared salpingotomy versus salpingectomy, your cumulative ongoing pregnancy rate after management of that ectopic was comparable, but you had a 15-fold increase of having persistent trophoblast if you had a salpingotomy rather than a salpingectomy. And your repeat ectopic pregnancy rate was about 1.6 higher in terms of your relative risk. So I think the numbers are small if you look at the actual patients that they reviewed those results in terms of persistent trophoblast and repeat ectopic pregnancy, but certainly this RCT demonstrated, and it's something that we're still widely practicing and counselling our patients with, is that if your other tube looks normal, a salpingectomy is preferable to a salpingotomy. What if the other one doesn't look normal? What do you do then? So this study performed a few years before that RCT found that if a woman had fertility reducing factors, and this is the devil in the detail, they defined this as either having a previous ectopic pregnancy, having evidence of contralateral tubal damage, once again not tested via dial tubal patency. This was a macroscopic look at this tube at laparoscopy. So for example, they saw some tubal adhesions in that contralateral tube, any history of abdominopelvic surgery, or a history of having pelvic inflammatory disease. They found that those women in this single centre study of about 260 women was that your subsequent pregnancy rate of having an intrauterine pregnancy was statistically significantly higher if you had a salpingotomy rather than a salpingectomy. Okay. Your repeat ectopic pregnancy rate was comparable in these women. And then if you remove those fertility reducing factors, then there was no difference, which then is supported by the RCT table above. Okay. What about medical management? So like we said before, methotrexate is the thing that we're only really using in current clinical practice. It's a folic acid antagonist interfering with DNA synthesis and cell proliferation. So that's why in rapidly growing tissue like trophoblast, it's very effective as a medical treatment. And it was sort of 1980s, mid-1980s that it first was published in the English literature to describe treating a patient with a tubal ectopic pregnancy successfully with methotrexate. And this was systemic. Various regimes have been tried since then, fixed doses, multiple dose regimes, different routes of administration, but really it wasn't until the 1990s that we developed the dosage of 50 milligrams per meter squared of body surface area that we're all currently using in our clinical practice, and this is systemic use. The way that we've all generally, I imagine, determine the success of a single dose of methotrexate for tubal ectopic is that you get a 15% or more decrease in serum beta-HCG levels from day 4 to day 7 after administration of the methotrexate dose. And then if we sort of round all of that up together, the only real big Cochrane review on interventions for tubal ectopic pregnancy was done all the way back in 2007. There's been no update since then, but that looked at 35 studies describing 25 different comparisons. And their primary outcome was treatment success with that first treatment. So that was an uneventful decline of the patient's serum HCG levels by that first initial treatment. And a failure was defined as either not having adequate decline in your HCG levels or needing another intervention, which would usually be further medical or surgical treatment. And so what do they find? Well, some basic, straightforward things that I think we all probably could have guessed ourselves. So methotrexate works better at a dose of 50 milligrams per meter squared versus 25 milligrams. This second study is quite interesting because it found that methotrexate has the same effect as expectant management. And that's been extrapolated in various different ways by different groups and research groups. I think, once again, devil's always in the detail. This meta-analysis here is based on one study published in 1996. It evaluated 46 women, so a small number, and they were either treated with placebo or oral methotrexate at a dose of 2.5 milligrams per day for 5 days. And it's well established that that dose is essentially a subdose, thought to be ineffective for ectopic pregnancy now here in 2026. So you could argue that practically they were comparing two placebos. So I think this is what the Cochrane review demonstrates, but I think picking out the details shows that maybe that's not entirely correct. Further looking into this argument of methotrexate versus expectant management, so 3 RCTs have been done, looking at that in detail. The first one was here by, I don't think it's that sharp yet. So Van Mello et al. In 2013, so 11 centres over 5 years, but it's interesting that the recruitment numbers weren't massive for such a large number of centres and study duration. Their inclusion criteria looked at those that had an ectopic on scan with an initial HCG of less than 1,500. This is interesting. So they treated or included women that were a PUL but had plateauing HCG, so essentially what we would call persistent PULs. And they treated them with single dose of systemic methotrexate, and they found that actually expectant management is useful and probably similar in its effects to systemic methotrexate when you've got those HCGs of less than 1,500. The main limitations were that it wasn't a placebo-controlled trial. The second study, so this is only one centre over 2 years with a small number. They only looked at ectopic pregnancies, and they found no difference between methotrexate and placebo, so essentially expectant management, if you have the low-level HCGs. The main limitations being single centre and small size. And then finally, the third study, so this was 2 centres over 9 years. They recruited 80 patients, so once again, really long recruitment period, but a small number considering how long that recruitment period was. Once again, looking at ectopics with an initial HCG of 1,500, and they felt that there was no difference. So I think there are limitations to these studies, but I think what the take-home message is that if you've got a woman who's clinically stable and her HCG is less than 1,500, then it's unlikely that methotrexate is going to have significant benefit over expectant management. And I think that's been demonstrated time and time again through a reasonable number of studies. So what about expectant management? So actually it was first practiced all the way back in the 1950s in terms of treating tubal ectopics, but really became much easier and more commonplace with the advent of transvaginal ultrasound scan as our primary diagnostic tool for diagnosing these women in the 70s and 80s. And then we discovered then that actually using serial serum HCG levels was a really useful adjunct. A study published in 2013 found that if you selected specific women, so those with a tubal ectopic pregnancy that were clinically stable, had an initial HCG of less than 1,500 and accepted expectant management, because that's an important consideration, is that out of all of their tubal ectopics, about 30% of women could be successfully triaged into expectant management, and about 70% of those would not require any further secondary medical or surgical intervention. And I think that's quite a useful thing to know. So, and I think certainly in the way that we manage women in our early pregnancy units, we're seeing them earlier, we're seeing them when they're much less symptomatic, we're picking them up a lot earlier. So actually it gives you this opportunity to, with a good evidence base, to very safely manage a specific cohort of your tubal ectopic pregnancies safely with expectant management. With that though, I think there's just a few points to make. So the first one is that how long is follow-up? Because the feeling is that if you're managing women expectantly, how long is this going to drag on for? Because medical and surgical management, well, certainly surgical, feels a lot more finite and quick, doesn't it? And a study looking at this demonstrated that the likely length of follow-up in that cohort who've got a low-level HCG to start off with, it's likely that the length of follow-up is about 3 weeks or under, okay? And then, as we'd suspect, that positively correlates with your initial beta HCG at diagnosis. So the lower your starting HCG, then the shorter the time it's going to take. The other really important consideration is how long does it take for you to not be able to see that ectopic on scan anymore, and is that important when you're managing these women expectantly? So we know that the physical resolution of a tubal ectopic mass takes longer if you have methotrexate, but takes even longer if you have expectant management. And so the authors of a study who looked at that specifically, I think, make an important point that when your HCG's gone down to negative levels, maybe you can't take that as complete resolution or the endpoint of expectant management, certainly if you've still got a reasonable mass that's visible on ultrasound scan. So this is an important consideration, I think, when we're talking to women and telling them about, you know, the follow-up and the pros and cons of all of these management options. I think that point is an important one to make. Certainly when they're thinking about planning future pregnancies and want to know the time interval until they can safely start trying again. So to summarise, if we just go through each of these points, so expectant, medical and surgical, obviously no intervention with expectant, varying success rates depending on what study you look at, because obviously different parameters have been used, but most importantly you can perform this on an outpatient basis, avoiding any risks of surgery or methotrexate. We talked about methotrexate as the mainstay of medical management at this dose, with a success rate of about 70% with a single dose and about 85% with 2 doses. Main benefits are that you can perform it on an outpatient basis, avoiding the risk of surgery, and about less than 10% will end up requiring second stage surgical intervention, but about 14% will require more than 1 dose. The main side effects, so, you know, when you're talking to women about them, the main one really is 75% get abdominal pain. The others are much less likely, just because we tend to find those in women who are having methotrexate for cancer therapy, really. We sign a consent, get them to sign a consent form saying that these risks are potentially going to occur, but at the low dose that we're giving them compared to for cancer treatment, and the fact that usually it's single dose, the other side effects are relatively limited. Importantly, I think it's all in the counselling, isn't it, that around 7% will require an emergency admission for surgery. And I think when we're talking to women about the things they need to look out for, and also considering the appropriateness of this treatment in a patient cohort, I think that's a really important consideration. Surgical is, of course, laparoscopy versus laparotomy. I think modern day medicine, most of these are being performed laparoscopically. And then we've talked about the pros and cons of salpingectomy versus salpingotomy. The main benefits of surgery is obviously that it's definitive one-stop, certainly if you're having a salpingectomy, a little bit of follow-up with salpingotomy for your serum HCG levels, but generally not hugely prolonged, avoids the risk of rupture, and potentially shortens the time until next conception can occur. We make them sign the consent form, talking about all the surgical complications that can occur, so obviously that's one of the disadvantages. And there's always a risk of persistent trophoblast with a salpingotomy. On a personal note, I think it's not hugely commonplace, I think generally in our practice, to perform salpingotomies. So I think the skill level is maybe not as much as it would be for other surgical procedures. I've certainly come across a few cases where I think technically it's very difficult to remove all the trophoblast. And certainly in my unit, we've had a few cases where we've ended up seeing HCG levels go up. You go back in, and then not only are you getting trophoblast within that tube that you try to do a salpingotomy on, but you're getting deposits of trophoblast that have then ended up elsewhere in the pelvis, which is an absolute disaster to try and remove. So I think the data exists for salpingotomy being a useful thing for women with a abnormal contralateral tube, but I think it's important to also think about how well we can actually perform that procedure and the potential sequelae if you need to go back in. So to summarise, I think safety first, diagnosis should be clear, and we should be ruling out intrauterine pregnancies before we even think about treating women with ectopic pregnancies. Because one of the RCTs that looked at methotrexate versus expectant management actually treated women who were classified as a PUR and didn't have a diagnosed ectopic pregnancy. So even in these big RCTs that are being performed, people aren't still getting their diagnostics exactly right. I hope I've been able to demonstrate that a lot of the studies that show the evidence that we base our clinical practice on are actually quite old. We're looking at like 90s, early 2000s, and many of them have issues with either study design, implementation. So I think it's reasonable to interpret them, but we need to do that with a reasonable element of sensible caution. And of course, at all times, it hasn't come up hugely in any of the studies or data about patient preference and what is it that actually women want. So what to do? So I think it's reasonable from all of that. I would say, in my opinion, if a woman is clinically well, it's reasonable, even if you found that tubal ectopic pregnancy on your scan, to wait for the first 2 serum HCG levels. And I think if her initial HCG is less than 1,500 and it's not significantly rising, and she's well, it is reasonable to manage her expectantly. If, of course, women on the other scale of things is significantly symptomatic, there's a hemoperitoneum, she's unstable, that's also quite easy, isn't it? She has surgery. And we prefer laparoscopic rather than open, salpingectomy if she's got a healthy contralateral tube, and then salpingotomy if there's any fertility-reducing factors, with caution. The indications for methotrexate aren't clear-cut, but I think it's a reasonable thing to consider in clinically well women who've got increasing beta-HCG, that you know you've followed up serially and it's not coming down by itself. Thank you very much.
Congratulations, excellent lecture. Do you have an upper limit of HCG for treating with methotrexate?
Yeah, so if you look at the NICE guidelines, they have set an upper limit of 5,000 international units per litre. I think in order to be pragmatic about it, I think what's probably more important is your trend. So if someone has an initial HCG that's 5,100, but she's really well, and it's small, and you're like, oh, that's quite high. And you're like, can I manage her safely? If you can manage the metal to do a second 48-hour HCG, and it's come down but then it comes up again and hovers. I think those are the kind of women where you could say, well, initially it was quite high, but they're clinically well and it's not successfully being managed expectantly. Should you definitely manage those women with metotrexate? I'm not saying that. Should you talk about it as an option, alternative option to surgery? I think you should.
Yeah, I'll just comment. I mean,
Yeah.
you have a conversation with Chris, but I remember Emma's paper on pre-treatment HCG. Single measurements of HCG generally aren't that great for anything, but I mean, a change over time is telling you something. Out of interest, what about progesterone, having a very low progesterone? Because that's something some people, I mean, people look at that as an index of viability as well. Is there anything to say about, you know, if your progesterone's 2 or something or whatever, would that influence your thinking at all?
I think when we've looked at it, certainly my experience of it within a research context is very much within women with a PUL. So we know that progesterone is a good marker, like you say, of viability. So if you don't know where the pregnancy is, then we know that it's likely to be failing if it's got a low progesterone, wherever it is. So it could be in the uterus, it could be an ectopic, it's likely to be failing. And it might be a good prognostic marker for those women that are more likely to be managed successfully expectantly. But certainly there's no good, robust data that's demonstrated that.
I mean, I think one of the things people say also, and I think Chris alluded to this earlier, is, and I remember talking to Bruno Caxitore many years ago, and he was talking about colour Doppler as a marker of successful expectant management. When it actually came down to it, the most important thing was, did they have pain? Pain.
Yeah.
You know, and actually all the other stuff, I mean, was kind of relevant. You know, do they have pain and do they start developing discomfort? And I think that's something to always bear in mind, is kind of the clinical picture, really, because we kind of forget that in the haze of the HCGs and all the rest of it sometimes. I don't know what you think, but
I don't think anyone would be criticised if a woman is symptomatic for offering her surgery.
But I mean, one thing before you say you have illustrated with this data is that, you know, if you look at that paper you cited, which people are basing management on, and it's 11 centres with 73 patients over 5 years. Well, you know, this is there must be a massive sampling error, recruitment error here.
Yes.
I mean, it's ridiculous because you're talking about 1 or 2 cases per centre over 5 years.
Yeah.
This is not a study, and it shouldn't, you know, really have been allowed to be published, because that's not okay. And you're basing management, and you're doing meta-analysis on this kind of stuff. Admittedly, surgical management trials are incredibly difficult to do, obviously, but it just, you know, goes to show where it's a very messy grey area, basically, I think, which we've got to be a bit careful over. There's a question over there, sorry.
I just wanted to ask, does a patent fallopian tube mean a functional healthy tube?
No, I think we have no clinical test for tubal function. We have a clinical test for tubal patency.
Well, there's your answer. One more comment. I'm going to...
Sorry, thank you for your presentation. In which periodicity we should ask an HCG for a patient that is managed in an expectant way?
Yes, what do you do? How often do you monitor them?
Yeah.
There's no set protocol that is used uniformly internationally or even nationally here in the UK. I think if they're having 3 or more HCGs that have continued to go down in a clinically stable woman, then it is reasonable, if she wants to continue with expectant management, to continue managing with 0 HCG levels, but then spacing them out a bit. So certainly in my experience, what we've done is that you bring them back weekly. With appropriate safety netting.
I remember there's an Emma Kirk paper that looked at, I think, if it's more than a 20% drop over the first 48 hours, then it's 80% specific for successful expectant management. And then after that, NICE says 48 hours, then 72 hours, and then weekly. But that whole protocol beyond that initial 48 hours is just what
making it
really...
Yeah.
And the other thing is, as you said, the methotrexate being between 1,500 and 5,000, and alludes to your question, Professor Timmerman, all the data looks up to HCG levels of 2,000. As a research community, we haven't been brave enough to do the much needed randomized controlled trial to see how effective methotrexate is
at the
between
high
2,000 and 5,000.
Yeah.
I think we'll have to leave it there. Shad, thanks very much indeed, as ever.